as Patrick mentioned, like you guys are, we do secondary stroke prevention. You guys do primary stroke prevention. So you guys, and also after patient have a stroke, like you guys are very well involved in those patient care, and you guys need to be very comfortable in taking care of stroke patients. And if there is any way that I could be helpful to achieve that, I would be more than happy to, including like if you guys have any request for any rotations with the strokes service, or if you have any other questions anytime, like you guys can call me, and I will be more than happy to answer that. So what we will do here is we will go through few things like about how we evaluate a stroke patient and how we treat them, and what kind of diagnostics we do, what are we thinking about, like when we are seeing the patient, what are the workup which we do, like, and why we do it, what are we looking into, like all the different scans we do, so those kind of things. And please feel free to stop by if you have any questions, you think about a patient and you have any question which it didn't make sense when you were seeing that patient, we can discuss about that. Like it will be nice if it is more interactive, but if it is one way, then hopefully I will give you enough information so that you feel comfortable evaluating a stroke patient. So we'll go through these, we'll define stroke, TIA, we'll go through a little bit of stroke epidemiology, like there's something called as Penumbra. We'll go through the concept of what Penumbra is and how we evaluate that. We'll go through a little bit on vascular anatomy, pathology, and risk factors, NIH stroke scale, classification of strokes. We'll be talking more about ischemic stroke, a little bit about hemorrhagic stroke, and then like what are the diagnostic we do, what do we mean by ELVO. You guys, everyone should know the term ELVO, like you guys know like STEMI and non-STEMI. In stroke world, there is a term which is recently, like within last 3 years, like it has been bounced, which is called as ELVO, which is emergent large vessel occlusion. We'll go through that, and a little bit about secondary stroke preventions, and then intracranial hemorrhage, and then about telestroke. So how do we evaluate a stroke patient? Like when I'm seeing a stroke patient, like my first thing when I'm talking to the patient, taking the history, examining the patient, I'm trying to localize the lesion. I'm trying to see, like, is it stroke is in the right hemisphere, left hemisphere, is it cortical, is it subcortical, is it brainstem? Why? Because when I localize the lesion, I'm going to be going to the etiology of the stroke, like because a large left MCA stroke could be a cardioembolic or atheroembolic stroke, which the management will be different if it is a lacunar stroke. So I'm trying to etiologize that localization, which when I go through the history and physical exam. So second step is etiologizing the lesion, and if you know the etiology of the strokes, then you will be able to better manage do the secondary stroke preventions in those patients. So if we have like a way that we think like, okay, localization, etiology, that's what we do the workup when the patient is admitted, and then like secondary stroke prevention. Is it like antiplatelets is needed, anticoagulation is needed, is a surgery required, or any other workup is required? You want to go through those. That's when we will be able to manage a stroke patient better. So how do we define a stroke? Like stroke and TIA as such, I consider them as the same because both is vascular phenomenon. It is abrupt onset of focal neurologic deficit, but when the patient has an damage to the brain via imaging, which we see on imaging, we call it as a stroke. Whether patient's symptoms are resolved or not, it's secondary now. Initially, we used to have TIA definition as less than 24 hours, symptoms resolved, you call it as TIA, but now the TIA is reversal of symptom but no damage to the brain. Whereas stroke is like even if patient has reversal, we diagnose them as stroke if there is damage on the brain, like when we do an MRI, if we find that. The epidemiology, like in US and worldwide, like ischemic stroke is much more common than the hemorrhagic stroke. Now these hemorrhage only includes any spontaneous intracranial hemorrhage, not the traumatic intracranial hemorrhage, which the number can be much high. In United States, it's the 4th leading cause of death and 1st leading cause of disability. Similarly, in worldwide also, like it's a pretty high leading cause of death and of course 1st leading cause of disability. In stroke, like as we know, like when brain is involved, there is physical symptoms, lot of physical symptoms that makes patient disabled, and that's why like we have disability. And that was the reason why I chose like vascular neurology as my career, because there are like several of my colleagues like didn't want to wake up in middle of the night, and emergency character like nature of the specialty, but I wanted to help those patients. Stroke being very dynamic, it is like you have to think through, like especially in the first few hours when the patient comes in, and how to treat those patients, and that can make a tremendous difference in patient life. It is extremely rewarding when we make a diagnosis and like we treat them with TP, and then patient gets up and like walks back to the nursing home, home or acute rehab facility. It is extremely rewarding, and I wanted to have that kind of rewards. So more about the stroke, like there are about 800,000 strokes happening in United States every year. Out of those, like most of them are first time stroke. A lot of them are recurrent stroke as well, like about 200,000 of them. Every 40 seconds, very expensive, as you can imagine. A lot of work days are lost when patient has a stroke, like because they cannot really go to work, and like if everything is taken into account, it amounts to a lot of billions of dollars. Blacks and Hispanics, race does have a factor in it. Black and Hispanics have higher rates than Caucasians. Somehow, like there has been some research which says that like in black population, sometimes there is the compliance with the medications is not as good, the education is could not be as good, but like even if that is excluded, there are some genetic reasons why black population have higher rate of strokes. So coming to the concept of penumbra, I want you guys to really understand this term. Penumbra is like whenever patient has a stroke symptom onset, there is this based on the symptom, like all the neurons which are causing the symptoms, not all of them are dead yet. When it starts, there is a very small ischemic core where the neurons are anatomically and functionally dead. They are not gonna are not reversible. Whereas right around the core there is this what we call as penumbra, where the neurons are still anatomically intact, but they are functionally they are not working. So that's when I put that theory of like workers who is asking for increased pay. If you are not going to increase the pay, workers are gonna leave the work, and that core is going to get bigger and bigger. So if you do increase the pay of those workers, which what I mean is like if we do increase the blood flow to that affected area, those workers are going to start working again. So those functionally silent neurons which were not working, they are going to start working again. And the time period for that can vary from patient to patient. There are patients who may have a penumbra like lasting for 24 to 48 hours, and then there are patients where penumbra is very small right from the get-go. The core is already big in first couple of hours. So we want to increase the blood flow, whatever way it is, be it like TPA, be it mechanical thrombectomy, be it permissive hypertension, but we want to increase the flow in those patients. One of the research which has been done has shown that kind of the core takes over the entire penumbra within first 24 hours. And that's why like you will see like when we see acute stroke patients, we keep their head of bed flat, permissive hypertension for first 24 hours. Because by that first 24 hours, most of that core is going to be will take over that penumbra. So in these first 24 hours, it's extremely important, and we want to save as much penumbra as we can by different modalities, treatment modalities. So going through the vascular anatomy, if you remember like how the arch of aorta giving 3 branches, brachiocephalic trunk on the right side and the left common carotid and left vertebral subclavian artery from the arch of aorta, and then common carotid divides into internal carotid and external carotid, and the subclavian artery gives rise to vertebral artery, and vertebral artery goes back to form the basilar artery, and then basilar artery divides into 2 PCAs. Internal carotid artery, after going into brain, divides into middle cerebral and anterior cerebral artery, and together it forms what we call a circle of Willis. And most of the patient do not have a complete circle of Willis. Most of the patient will have incomplete circle of Willis, where patient may not have a PCOM, or patient may not have an absent first segment of the anterior cerebral artery or things like that. And we see that very commonly. So circle of Willis most of the time is not complete. Like in this example here, we are not seeing any PCOM like on both the sides. So this patient does not have a full circle of Willis either. So, thinking about the pathogenesis, thinking about what could have caused the stroke, like we classify the ischemic stroke as Toast classification. There is something called as Toast classification, and again, this is only for ischemic strokes. We divide it like any patient who comes in with stroke symptoms, you should be able to put them into one of the 5 categories. One is large vessel disease, so patient having carotid stenosis or MCA stenosis, something like that, large vessel stenosis or atherosclerosis. Second is cardioembolic, so coming something from the heart, which is very commonly seen in our patient group. Third is lacunar, so patient who have like lot of medical vascular risk factors, they having those lipohyalinolysis of those penetrating branches which originate from the MCA or PCA going into the deeper subcortical areas, lacunar strokes. Fourth is stroke of other etiology, where patient may have dissection, patient may have hypercoagulable disorder, patient can have hypercoagulable disorder because of cancers, and then like a cryptogenic. Cryptogenic is quite big category, about 25 to 30%, and that's why we do much more aggressive workup on patients like when they come into our service. Patient, like we are doing more and more of link device procedures in patients who looks like they have an embolic stroke, but we did not find anything on the echocardiogram, we did not find anything on the carotid, we didn't find any specific etiology, and we do link procedure and we monitor their heart rhythm for as long as 6 months, 8 months, and then we end up having patients having atrial fibrillation, which could have been the cause for the stroke, and we start those patients on anticoagulation. So one of those 5 categories we should be able to put them in. And then like hemorrhagic stroke, which is less common, spontaneous is like intracranial hemorrhage, like intraparenchymal hemorrhage, or it could be subarachnoid hemorrhage, which is mainly because of aneurysmal rupture. So risk factors, which is where you guys can make a big impact, is like I divide them into modifiable risk factor and non-modifiable risk factor. The modifiable risk factors, which is where we can do different things about the care, about the patient care there, including essential hypertension, diabetes, high cholesterol, patient who are smoking, having atrial fibrillation, any other vascular risk factors. We can change the dietary habit, we can change the lifestyle do the lifestyle modification, which can help to help with those modifiable risk factor. And then non-modifiable risk factor, we cannot really do much about it, and we hope that that does not affect the patient even after controlling all the vascular risk factor. We do have occasionally some patients like where all the vascular risk factors are so well controlled, but they end up having strokes because of some of the other non-modifiable risk factors, which we did our best. Some patients do not respond to medication. They are on good antiplatelet, anticoagulants, but they did not respond to them. So there are things which we cannot really change, but our focus should be on the things which we can really change and make a difference. So when patient comes in, like we do the NIH stroke scale, which is a scale which is standard which is being used throughout the world. It is to determine how bad the stroke severity is. It ranges from 0 through 42. 42 is being dead and 0 is like completely normal exam. And based on the score, like we determine like how we just judge whether that patient has any significant clinical findings or not. It's not everything about the clinical exam, because like a patient with NIH stroke scale of 1 could have just sensory symptoms, or patient could have aphasia, which is sensory symptom is really very mild. We may not treat those patients with TPA with that, but if patient has 1.4 aphasia, then we should treat those patients, because that is a clinical disabling deficit. So when somebody tells me that like NIH stroke scale is this, I will ask them what are those points with. But if somebody says NIH stroke scale of 24, 26, I know that it is pretty severe variety of whatever is going on. So this was the classification I was talking about, the TOST classification. We should we should try to put that any ischemic stroke patient into one of these categories to help us manage the patient well. Signs and symptoms of stroke, like which you guys probably do know well. It is sudden onset of one-sided weakness, numbness, difficulty talking, difficulty walking, severe headache. But it is all suddenly patient starts having the symptoms. I'm not gonna go through all the key stroke syndromes, but like if there is these are some of the main key syndromes which we see on a regular basis: left MCA or left ACA, or a combination of those when patient have left ICA occlusion, right MCA. Then we have posterior circulation. I always divide the vascular territory into 3: right anterior, left anterior, anterior and posterior. Those 3 vascular territory, and like patient can have symptoms. And when I see patient having stroke in more than one vascular territory, like I think about like having a central source for the embolism. And then lacunar syndrome and some spontaneous intracranial hemorrhage. What are the different diagnostics we do? We do, like when the patient comes in first, like the first thing we do is a non-contrast CT scan. Why do we do a non-contrast CT scan when the patient comes in first? What are we looking for when we are doing a non-contrast CT head? Hemorrhage, right? Like, what about ischemia? Can you see the ischemia when the patient comes in with stroke symptoms? Maybe. So when do we start seeing the patients with ischemia? Patients about 4 to 6 hours, like after the symptom onset, like patient can start having changes if it is ischemic stroke. And that's why, like when you are one of the inclusion criteria for TPA is a normal CT head. So there is no hemorrhage, but also like the ischemia is not being seen yet. In our center, we do CT angiogram and CT perfusion in all the patients acute patient who comes in. Not everywhere that happens. MRI brain with and without, depending on what are we looking for. Carotid ultrasound, cerebral angiography, transcranial Doppler. Occasionally we do that. This is during the hospitalization. Every patient may be different. Like we may do in some patients versus some other we may not. There is something called as aspect score, which is what we calculate in every patient who is an acute stroke patient, especially who has an possible elbow, like large vessel occlusion. It's measured, like it is called as poor man's perfusion scan, because it is because to evaluate that penumbra which I was talking about. If patient has a complete left MCA syndrome, suppose, so complete right-sided weakness, aphasia, gaze deviation, then I would want to know, like I would expect that as there is lot of hypodensity in that entire left MCA territory. But when we do a CT scan, if patient is very early in time, when we do a CT scan, the patient CT scan is not yet showing that hypodensity. So there is that clinical and radiological mismatch, and that mismatch is what is penumbra. And because the reason it is called poor man's perfusion is because this is based just out of the plain CT head. And there are like 10 points, we give like 1 point for 10 different areas, and if I see any hypodensity, I'm going to take that point out. So 10, if the score is 10, it is normal CT head, versus if score is 3 or 4, like that is a poor scan, that patient is going to have a large core already. So core is going to look like, it will look hypodense in there. And it's mainly used for MCA strokes. Like again, you do not need to know each and every areas, but like this is mainly for MCA territory. We look at score at two different slides. At a nuclear level, where we see all the nucleuses like thalamus and all those other nucleuses, and supranuclear level, and we will look for hypodensity, and then we will see if there is a clinical and radiological mismatch. And if patient has score of 6 or more, patient can still be considered for mechanical thrombectomy. That is a favorable score when we see that. This is what we do when patient comes in, CT perfusion. We have this new software called as Rapid software. What it does is, it will measure the core and how big the entire affected area is. So pink, what we are seeing is the core, where the neurons are anatomically and functionally dead. They are not going to reverse. It is irreversible. And the green is the entire area which is affected, which is causing the symptoms for the patient. So any difference between that two is what we call as penumbra. And this, if you look at this, like there is quite a bit of asymmetry between the two sides, and then there is also mismatch between the two slides. And we monitor CB, cerebral blood flow, and we monitor perfusion, which is Tmax. Again, you don't need to know that, but you can clearly see the difference between the two, and that's what the mismatch is, and that's what the penumbra is. So these kind of patient, you want to be very aggressive, because there is a lot of brain which you can still save. That this is where like you want to increase the blood flow in any way you can. So these are again the different scans which we do: CTA head, CTA neck, MRI brain, cerebral angio. And what other additional workup we do for stroke patients, like we do echocardiogram in most of the patients, because oftentimes we do find patients like who may have more than one etiology. Patient may have carotid stenosis, but patient may also have atrial fibrillation or a thrombus sitting in the heart. So we do see that sometimes. So we do echocardiogram in all the patient. We check the blood vessels in all the patient, and transcranial Doppler as needed, carotid ultrasound as needed. Like it depends on what we see on the CT angiogram. Yes, ma'am. Transcranial Doppler is to see many times, like if patient has abnormal kidney functions, that's why you are not able to give contrast to them, and you cannot do MR because they may have a pacemaker. That transcranial Doppler will see how the blood flow is in the intracranial blood vessels. Like what we do carotid ultrasound for carotid, transcranial is for all the intracranial vessels, and it will give us the velocity of MCA, ACA, posterior cerebral artery, basilar artery. So you kind of know like if there is any major blockage. No. In lacunar we cannot really see blood vessels, because those blood vessels in lacunar, the affected blood vessels, are microscopic vessels. So we usually do not see them. Now sometimes we do see that patient have lot of atherosclerosis of intracranial blood vessels, which those patients can have lacunar syndromes. So what do we do for acute stroke patient? We save the penumbra. That's what our goal is. Like, how do we do it? We do TPA, tissue plasminogen activator, which is we go through the inclusion and exclusion criteria. My hope is like eventually a time will come when we won't have the or criterias, but rather we'll have imaging criterias where if patient have favorable imaging, you may still end up giving TPA, because there are times when patients may have like a large penumbra, but they are more than 3 hours, but so that we end up not giving TPA to those patients. But I hope that eventually we will be able to do that. But again, those hours in that it will need to happen within first few hours, because the neurons die really quick. Every minute, like neurons don't get the blood flow, like about almost 1.9 million neurons die every minute. The blood flow is affected. So we do TPA, mechanical thrombectomy patient. We'll go through the groin and pull the clot out. We do that. We ask the patient, put the patient's head flat, because that increases the perfusion pressure, and it has been shown several times that like how patient's symptoms improve, like when their head of bed is flat and you raise them up and their symptoms starts occurring again, and those patients have a bigger penumbra. Permissive hypertension, the same reason we want to increase the cerebral perfusion pressure. Usually we do that for first 24 hours, because most of the time that in first 24 hours that core will be take over the penumbra. Inclusion and exclusion criteria, like FDA has approved TPA only up to first 3 hours, but there is a trial done which showed that there could be additional benefit in some other patient up to 4.5 hours. But there are those additional exclusion criteria for those patients which are as written, which is a severe stroke patient, any patient who was on oral anticoagulant, doesn't matter of INR, history of hypertension, diabetes and stroke together, and if patient is more than 80 years of age. So basically in that trial they tried to exclude more severe patient, and that's why like patient probably did have some good outcomes. Now TPA works in all the stroke subtypes, like whether it is lacunar stroke, whether it is large vessel stroke, TPA works in all the patient. Of course, if the clot burden is too big, like suppose if there is an ICA occlusion, TPA is not going to work as much as if there is a MCA occlusion or a distal middle cerebral artery occlusion. So every patient is going to be different, but like TPA works in all the category. We have seen TPA dissolving clots like in ICA occlusion as well, but usually if it is very early in the course, like if you can give it within first 60 minutes or so, then the chances of improvement is much better. These are the inclusion and exclusion criteria, like which again, like you don't need to know each of them, but like it will be good that if you know most of them. Inclusion criteria is only 3 mainly. It is clinically disabling neurologic deficit, patient is CT scan is normal basically, and then patient age is more than 18 years. We have given TPA to less than 18 years also, like in between 13 to 18, but it is not recommended. And then exclusion criteria, like based on what it is. And then these are some additional exclusion criteria, other additional exclusion criteria for 3 to 4.5 hours. In Europe actually, like the TPA is approved up to 4.5 hours. So in United States it's not approved for some reasons. So ELVO is what I want you guys to know, like emergent large vessel occlusion. Earlier, like until 2014, there were few trials which were done for large vessel occlusions, but they were not positive. But then in 2014 onwards and in the subsequent 2 years, there were at least 5 to 6 trials which came and they looked at the large vessel occlusion differently, because they looked at they included only patients who had evidence of large vessel occlusion. So like if they saw MCA occlusion or ICA occlusion on imaging, on CTA, and then if they had a good perfusion imaging, they excluded all other patients. So that's why I think the trial became more positive. But the positive effect is so good. If you see the number needed to treat is just 4 to 7. Like 1 of every 4 to 7 patients treated had a very good outcome compared to if patients were not treated with mechanical thrombectomy. This number, like if you want to compare with STEMI results, like it is 1 in 17 for patients who have STEMI, like who go to cath lab. So it is extremely one of the most positive trials that we have seen in the history of medicine. So it is extremely positive, but like you have to choose the patient very wisely. So any patient who comes in, these are the large vessel occlusion. So internal carotid artery, middle cerebral artery, anterior cerebral artery, posterior cerebral artery, or basilar artery. If there is any occlusion which you can see on CT angiogram, then those could be like potential cases for mechanical thrombectomy. Now that can be done only up to 6 hours after the symptom onset. So when you are evaluating the patient, we want to know what the last seen normal of the patient is. So if patient woke up with symptoms, the last seen normal is the night before. But if somebody had noticed the patient completely normal, that's what the last seen normal will be. So we want to really know what the last seen normal is, and within 6 hours, if patient has any of these, then we can potentially treat those patients with mechanical thrombectomy. Still, if patient is within 3 hours, the patient gets the TPA first. And while the TPA is going, we call the cath lab and we take the patient to the cath lab and start the mechanical thrombectomy procedure. And if it is more than 3 hours, up to 6 hours, we can take them directly to the cath lab. And again, that depends on how the patient's symptoms is. Like when you are localizing the lesion, if patient has complete plegia on one side, chances are that they will have a large vessel occlusion. If patient has any cortical symptoms, if patient has aphasia, if patient has gaze deviation to one side, if patient is not able to talk, is neglecting one side completely, those are some cortical signs which potentially could be large vessel occlusion. And if you see any of those cortical signs, right away, like you should, when you call the neurology team, if you say that this patient looks like elbow, everyone will be really fast. Like, I mean, much faster than maybe TPA, as well. So, you want to know this term elbow. And then one of the trial have shown that every 30 minutes delay in perfusion is going to decrease the outcome, increase the chances of worse outcome. So, and then if patient is ineligible for TPA, what do? We try to improve the perfusion pressure by doing this permissive hypertension. And then secondary stroke prevention, I'm not going to go into much more details, but we do antiplatelet agents, depending on what the patient is on. Sometimes we check the platelet function test, we check the aspirin response, Plavix response test to see if patient is really responding to those medications, and we may change from one antiplatelet to other antiplatelet agent, but most of the antiplatelet agents, like when they had done the study in strokes for stroke prevention, it has shown that it probably is not a lot different between aspirin and Plavix versus Agrenox kind of picture. Then depending on what you find on for the etiology of the stroke, you may need to do anticoagulate the patient, whether patient is eligible for Coumadin or newer anticoagulant agents. If patient has thrombus, if patient has any kind of aortic arch finding, depending on whatever we find. Statins is a must in all the stroke and MI patients, as you guys know. We go through those modifiable risk factor. We want to control as many as of them. Of course, lifestyle modification for those patients, and we want to talk to them about that as well. So any questions on ischemic stroke patients you would like to ask? anytime, like if you have any patients like who has sudden onset of neurological changes, you guys feel free to call us, so we can respond and we can evaluate the patient right away. Spontaneous intracranial hemorrhage, quickly, mainly 4 different kinds, like intraparenchymal hemorrhage, subarachnoid hemorrhage. Sometimes subdural can be spontaneous, because like a very minor injury can also cause, like just head jerking in a very old patient who have lot of atrophy, they can have subdural like with very minimal trauma. And intraventricular hemorrhage could also be hypertensive hemorrhage. When you see a lobar hemorrhage, there are some other differential diagnoses which you want to think about, because hypertension usually do not cause a lot of lobar hemorrhage. Hypertension usually cause more of like subcortical hemorrhage in thalamus, putamen, pons or cerebellum. But when you see lobar, you want to think about like tumor, metastasis, if patient has vasculitis, if patient is on any drugs. Cerebral amyloid angiopathy is one of the reason, like we have one patient right now who has exactly similar bleeding and has cerebral amyloid angiopathy. And then venous infarct is something which you would want to think like in patients who have like unusual strokes, hemorrhage in lobar areas. When patients do have intraparenchymal hemorrhage, you want to calculate the ICH score. Based on the ICH score, you can kind of determine what the mortality of those patients could be. The higher the ICH score, the worse the mortality. And you can see like from 1 to 2, like if the score increase, like the mortality changes, the number increases significantly. So and then how you score them, like you look for GCS, age, location, intracranial hemorrhage volume, and if there is intraventricular blood or not. And then spontaneous subarachnoid hemorrhage, it is because of aneurysm unless proven otherwise. One of the big risk factor, hypertension, smoking, any family history, very high risk for having aneurysm in the family. Patient who have some connective tissue disease, they can have aneurysm. And then like Tele-Neurology, a little bit about that, like which we are doing, we are trying to establish our program. We have about 4 hospitals right now where we are doing telemedicine. We are starting with stroke, but then we are gonna advance it to more neurology as well, general neurology. One of the clinic and Taylor Regional Hospital, we have started providing clinics as well for different subspecialty other than stroke. It helps a lot. One of the hospital in Jasper, Indiana, we are able to keep the patients in that hospital, and we are rounding in those patients. We use the robot, and like every day we see those patients. Some hospitals where they are not very comfortable, only stroke patients are transferred, non-stroke patients, they are able to manage it over there. So lot of advantage of telemedicine. And like even one step further would be this, like which is already happening in some of the facilities where ambulance is equipped with CT scan and telemedicine equipment, and neurologists are looking at the patient in the ambulance on the driveway, and they do a CT scan, and then like they look at the CT scan. So giving TPA on the driveway, which increases the outcome, which improves the outcome significantly. So hopefully we will be able to do this sometime as well. That's about it. Any questions?
So here at this hospital, if they're grounding and they suspect an acute stroke, who should they be paging? The on-call
stroke attending? Just over here, like any new patients, we want to communicate with stroke attending directly. The reason is like sometimes like the emergency, because if I call the resident, like they will respond right away, and then like I can call my stroke operative nurse, like who is also there, like so they can get everything on together.